Yeah, so 3, 2, 1, and we are live now. We can start with the session.
Yeah. Good evening, everybody. This is another ILD MDM Friday, and as I earlier said, this is sarcoidosis special. We have got 4 sarcoid cases, and we are really happy and honored to have Professor Athol Wells, who, along with Dr. Vasilis, is the only, like, they coordinate and conduct arguably the best cardiac sarcoid referral center of Europe. We have got the counterpart of India with us, and that is Dr. Sajal Dhuria. And we are really we are going to have a great discussion along with them. Along with them, we have got Dr. Vimal Raj, who is expert radiologist. We have got Sharda, who is our pathologist. And I'm going to expect Dr. Sujit Rajan, who is held up with something, and he will be joining us later. Deepak Talwar sir is also held up with something, and he might join us later. We have got Dr. Sanmukh Sundaram sir, who is the only nuclear medicine expert which I know about. So thank you, sir. Thank you, all of you. And Dr. Katrina might join us if required. Dr. Sanjay and Umang are from Glenmark, who are our technician who are going to support us technically. So shall I just start sharing my screen, Professor Wells? So I will start with the case 1. I hope my slides are visible.
They are.
Okay, good. Okay. So this is a 48 years old gentleman who had type 2 diabetes since 2012. He was relatively all right almost 5 to 6 months before, when he started having cough and breathing difficulty. And over 6 months of time, he had weight loss of 10 kilogram. In January 2024, he presented to outside hospital in the cardiology department for chest pain and shortness of breath. Initially, they thought it is an old changes, but within 1 day, the changes were more progressive, and diagnosis of acute anterior wall MI was done, and they tried to recanalize. However, on February follow-up echo, there was a global hypokinesia and ejection fraction of 30%. He also had left-sided pleural effusion. There was no tapping done, but I believe it might be labeled as a Dressler syndrome. I do not have report of his. So this was happening in January. In February, they did a CT scan and they found there were lymph nodes, and also they did BAL inconclusive. In March, they did bronchoscopy again. And this time they tried to do FNAC from the 4L and station 7 lymph node, which also came inconclusive again. Outside echo was repeated in May because he was just worsening and he kept on losing weight. It was again ejection fraction of 30 to 50%, 40%, and 24-hour Holter was negative. So here is a gentleman who presented with predominantly cardiac problem and weight loss, along with dry cough and dyspnea. When he came to me, he had some skin lesions also, which I consulted my dermatology department, and they told it is just PIH, that is post-inflammatory hyperpigmentation, nothing else. We didn't do biopsy of it. He was relatively stable with 96% room air saturation and weight of 54, height of 165. The reason I was worried about him was his calcium level, total calcium was 15.8, and I didn't have a window period of waiting for biopsy on trying and erring and all. His creatinine when he presented was elevated. He is already diabetic, and he had some ALP and GGT elevation also. So this was the case when he came to us. The main problem was he had some cardiac problem. His heart was bad. He had hypercalcemia. I was worried about how to hydrate him when his heart is so bad. So our ejection fraction was around 50%. We did some ancillary tests, which was just hypercalcemia related. His ECG at the time of presentation was something like this. And this was his spirometry, FVC, FEV1, DLCO, and 6-minute walk test. So this is what he was about. And now I will stop sharing and I will give it to Vimal Raj sir for showing the images.
Perfect. Thank you very much. Very good evening to all of you. So this is his CT scans, and these are from February 2024. They are part of a PET-CT examination. And on the right-hand side, what you can see are these lymphatic tissue already starting along the retrosternal area, mediastinal stations, large lymph nodes, with some of them showing matting in the subcarinal, extending into the hilar bilaterally. When we look at the lungs at the same time, what we can start to see are these fine nodular tissue, bronchocentric nodules, and also you're able to see some fissural nodularity bilaterally across. And these are predominantly perihilar in location, and these are spread in the central area, not going towards the periphery. At this point in time, there's no pericardial effusion that we can see. There's no pleural effusion. The corresponding PET-CT, we can see here, there were lots of lymph nodes. The mediastinal lymph nodes, the hilar lymph nodes are all lighting up. And there were lymph nodes also going further down into the abdomen. We can see across retroperitoneal lymph nodes across. So all of this points more to a sarcoid, very clear case on the HRCT across here. Do you want me to show the follow-up one, or shall we stop here for a second?
Yeah, we will stop here for a second, and if you can stop sharing, I'll just show mine. So then what happened is, as I told, I didn't have a time, and I was forced to have some MDM, and I was forced to start him on steroids. And we decided, I consulted nephro, I consulted endo, I consulted rheumat and myself. We all decided that he has calcium of 15 and I cannot leave him like that. And this, as sir told, these were the images, everything was going in favor of sarcoidosis. Even if I have to do something about diagnosis, I can do later. I started him on methylprednisone 500 milligram IV OD for 3 days and tapered to 60 milligram, which was continued. And because cardiac MRI was requiring some preparation, I bought that time. And surprisingly, he improved also. He was not in such a bad shape by the time we sent him for cardiac MRI. I will stop sharing and Vimalraj sir can take. So this MRI and PET-CT was done. I think cardiac MRI was done in our hospital after I gave him 3 doses of methylprednisolone, 500 milligram.
So I will plead my ignorance to the...
I think Sanmukh Sundaram sir is there, sir. Yeah, he can just unmute and talk.
Good evening, everyone. I think it's a great opportunity for me to show what is the relevance of an FDG PET-CT and an FDG PET-MR in a suspected systemic sarcoidosis and also possibly in the cardiac sarcoidosis. Here, what Dr. Vimal has shown initially is an image done somewhere else, but please understand and please note the fact that this was done more as a possible generalized lymphadenopathy evaluation. So the patient was not prepared. Let me explain what exactly we mean by preparation later. So as you know, FDG, fluorodeoxyglucose, is a radiopharmaceutical mainly used for the evaluation of malignancy, but it's also taken up by infective and inflammatory cells. Being a glucose molecule, this is taken up by the glut receptors in both inflammatory, infective, and also malignant cells. And you can show the lesions in a whole body imaging. So what Dr. Vimal nicely showed was multiple mediastinal lymph nodes and also infradiaphragmatic lymph nodal lesions. But the CT findings are more in favor of possible inflammatory origin, and the clinical symptoms also was fitting to that. So possibly a working diagnosis of sarcoidosis was made. But there are lots of points to be noted at this point in the sense this is a patient with severe LV dysfunction, and he is also a post-pacemaker implanted patient with a significant AV block. And at that time, the role of cardiac PET MRI and the imaging of cardiac sarcoidosis comes into picture. So when we do this cardiac MRI and the whole body imaging, because we have the equipment with us, the whole body PET MRI 3 Tesla imaging, we were able to do both whole body imaging and also we did a cardiac MRI. So both were done in one go. And it's very important for us to understand here, we need to know that there is proper preparation. So as you know, 15% of the myocardial substrate or energy substrate is provided by the glucose. So we need to suppress that. Then only we can assume that whatever the abnormal uptake that is there in the myocardium can be taken into consideration as abnormal. So three ways of doing it. One is complete cessation of carbohydrate food. It is very difficult in an Indian setting, but it has to be done. So we have a strict diet criteria. Patients are encouraged to have only fatty and protein food for the previous 3 days, and they are completely stopped from taking carbohydrates. So this is one way of starving the myocardium from glucose or carbohydrate. The second way is prolonged fasting. Patients are made to fast for a minimum of 12 hours to a maximum of 18 hours. This is the second way. And third way is to inject unfractionated heparin intravenously, 50 units per kilogram body weight, 30 minutes before the injection of FDG. Thereby, we mobilize the free fatty acid from liver into the circulation. Thereby, the uptake of normal glucose is completely suppressed. That is how this patient is prepared. So then whatever the uptake in the myocardium can be taken as abnormal. That is one. Second, the another advantage of doing a whole body imaging in this particular patient is the extra cardiac sites like lymph nodes or any other soft tissue lesions in liver, spleen. All those things can also be evaluated. So that is the biggest advantage of doing a whole body PET imaging, whether it is a PET CT or a PET MRI. But here, I'm sure all of you had got the point that we were able to do a cardiac MRI plus a whole body MRI imaging. So in this particular patient, because Dr. Asmita has used steroids for the previous month, he shows all the lesions, although anatomically present, is not showing any uptake, neither the uptake in the cardiac muscles or myocardium or any other lymph nodes. So it clearly shows that patient has significantly benefited by the steroid therapy. That is the next big advantage of doing a cardiac sarcoidosis or systemic sarcoidosis FDG imaging, that whether patient is responding to our systemic therapy or not. So these are some of the points which we are learning from this particular patient. Thank you.
Yeah, and this is
So we,
Yeah.
I'll just quickly show the follow-up
Yes.
as well, please. This is the two scans. This is from, the right one is from February and this is from May of the same year. What we are seeing is, as far as the lung parenchyma is concerned, a lot of the peribronchial inflammatory changes or nodular changes have reduced. Still, there are few nodular changes, but the visual nodularity has also gone down between the 3-month scan. Still, some inflammatory changes are there. And if we look at the mediastinal changes at that time, the lymph nodes are still persistent. So between February and May, the nodal tissue hasn't changed. Mild decrease in the parenchymal inflammatory changes.
Yeah. So if you can just stop sharing, I'll share my questions to the panel.
So probably at this point, just wanted to highlight the relevance of FDG PET as it was shown structurally, CT-wise, you are still seeing the lymph nodes, although there is a mild reduction, but still the FDG is completely negative. So the metabolic resolution of the lesions are nicely shown.
Yeah, agreed. So I actually after 3 days and just before PET, I think, or after PET, I think before PET I did EBUS. And these were the lymph nodes and it was subepithelial granuloma. He was like, we wanted to confirm the diagnosis. I was just waiting for his calcium to come down and we can see nice granulomas and this particular Schaumann bodies and everything was present. So to summarize, he is a gentleman with normal PFT. He has very elevated calcium. He responded well to steroids. My questions to the panel is, if cardiac MRI and PET did not show uptake in the heart, is it enough to rule out sarcoid? And should we start second-line agent upfront in view of life-threatening sarcoidosis in this case because he presented with kidney failure and he's hardly 40s? and what is the expected disease behavior, how long we should be treating, and suggested management plan. I can stop sharing and we can go one by one, or you panel can take one by one question. So cardiac MRI and PET, sir has answered. So to Athol Wells, sir, and I think Sajal Duria. Yeah, stop sharing.
Yeah, so can I come in now? Because once Dr. Wells speaks, then it may be the final word. So
yes, please. Yeah. Go ahead. Yeah.
Right. So yes. So I have few points to raise regarding the case, and then I'll also come to the questions.
Sure.
So one is it may not be in a particular order, but the way I noted down as you presented it. One is the diagnosis of sarcoid. So the diagnosis of the systemic involvement with sarcoidosis is not under any doubt in this particular case, because we have a consistent clinical picture, consistent radiological picture, and granulomatous inflammation demonstrated in a EBUS TBNA sample. So I don't think the diagnosis of sarcoidosis is in doubt, although we have sometimes maybe 1 in 100 cases which are or maybe 5 in 100 cases which are typically sarcoid on the entire clinical, radiological, and histological picture, have a negative tuberculin skin test, have a negative interferon gamma release assay, they still prove to be tuberculosis. So we have heard once or twice in such cases where we started with steroids and immediately TB came up. Immediately meaning within, say, 10 to 14 days. If TB appears later in the course of steroid therapy, it could have been a reactivation. But if in a patient with granulomatous inflammation, if the TB comes up so early after steroid initiation, it might all be tuberculosis or an overlap of the two diseases. This we can take up later. But for now, the diagnosis seems to be sarcoid on a systemic level. The next question is whether the patient has cardiac sarcoidosis or not. So for that, I think we need more details on coronary angiography and perfusion imaging.
Coronary angiography was negative. It was done outside. It was negative, and they didn't commit anything. They thought it is anti-revolve MI and treated it. There was LAD block and which was corrected. However, anti-revolve MI was there.
They thought that it is anti-revolve MI, but with a normal coronary
normal angiogram. He showed me the report. It was not repeated in our hospital. Yeah. Patient was, I think patient came to me because of some reference. Yeah.
Dr. Duria, can I come in?
Yeah. Yes, sure.
Yeah, so once again, I am Dr. Shanmuga Sundaram. I am the nuclear medicine physician, and I have done a rest perfusion study on this particular patient. As a protocol in our institute, we always do a perfusion study because it helps us to know, is it a burnt out sarcoidosis, cardiac, or is it an active one? So in this particular patient, as you rightly asked, he had very severe perfusion defects. These defects were not only confined to the LAD territory.
I am sorry to interrupt you, sir. You are mistaken. This case is not the cardiac, this defibrillator was implanted. This is another patient who had negative cardiac MRI and negative everything. This is a case. Yeah. This is not the case of that MRI which came positive, because this is another man whose everything was negative.
No, it is, I think, Jose only.
No, this is not Jose. This is another man. That's why.
Okay. So we don't have a perfusion.
I think I am sorry to interrupt you, all of you, but we are just 5:23. I have 4 more cases to discuss, so we can quickly discuss only questions. This is MDM only for questions, so that is why, Sajal. So sorry to interrupt you, but if we will just pinpoint the questions and answer the questions, so that will be then we can move to second case.
Okay. So could we go through the questions again?
Sure. I will do that. I will share my screen once again, and we will just stick to the questions for as of now. Yeah. Is it visible?
Yeah.
Okay.
Yes, I can see that.
Yeah, sure. So you can answer, and then we can go to sir, and we can go to the next question. Yeah.
Okay, right. So the first question is whether if there is a negative cardiac MRI or PET, is it enough to rule out cardiac sarcoidosis? Not really, because maybe 10% of the times the cardiac MRI can be negative, but mostly it is not a clinically significant disease if the MRI is completely not showing anything. But in your case, you had already treated the patient with immunosuppression.
Yep.
So we cannot be really sure whether what a negative MRI means.
Sure.
The time difference between giving the steroids and the MRI should be an
Was
important
hardly
thing to
hardly 1 week. Hardly 1 week.
look at.
Yeah.
But again, there is no way that we can really say. But yes, maybe Dr. Wells will be
Yeah,
may
sure.
make a comment here. I think we can take up one question at a time because sir,
Yeah.
Dr. Wells, please.
Can I have permission to make a general summary of the case? Because
Yes, please.
I really do think
Yeah,
that
yeah.
going question by
Yes.
question doesn't meet the needs of this discussion.
Mm.
Just to get diagnosis out of the way, if you're likely to have systemic sarcoid and you're likely to have cardiac sarcoid, one likelihood informs the other, and you end up being confident of both. The Japanese diagnostic criteria allow typical advanced imaging plus a clinical and lung imaging profile. I don't think an alternative diagnosis is plausible on that scan. You see beading especially. And so I'd say the diagnosis is secure. But to me, there are the following issues. Firstly, on that first PET, I take aboard the signal outside the heart, but what I saw in the heart looked like dietary failure. And I do not know if there was any inflammation in the heart to begin with. Secondly, I haven't heard that the MRI provided a classical cardiac sarcoid picture. And because there's an acute onset, I think you have to go through the pathways of whether this is a patient with sarcoid, with cardiac involvement, or whether this is a patient with sarcoid, with an alternative, more acute cardiac process, such as a myocarditis. We've heard actually that in spite of the presentation, it probably wasn't ischemic heart disease. And especially in judging management, if I don't know if there was inflammation in the heart to begin with, how do I then decide how I manage that in the long term? Now, I will say that if you've got major inflammation in the heart, in my experience, it doesn't vanish with a month even of high-dose immunosuppression. So if you're completely negative now, I think you've got to ask whether if this is really cardiac sarcoid, and I think the odds favor it, if it's really cardiac sarcoid, is this a case where the damage has been slower over the years, but the inflammation is burnt out? Now, we use MRI primarily for scar tissue. If you see stir edema, that is indeed predictive that you'll see quite a lot of signal on PET, but time and again, an MRI hasn't identified prominent inflammation that you see on PET. So we've got three domains, echo, MRI, PET, dealing with function, scar tissue, and inflammation. And for management, I'm somewhat disadvantaged here because I don't know what the real inflammation signal in the heart was to start with. Now, I understand you had to treat because of hypercalcemia. I would be very worried about your regimen in a type 2 diabetic.
Yeah.
I agree with methylpred, but the advantage is you can get the steroid dose down quite quickly. And I think 60 milligrams daily in a patient with type 2 diabetes, when we're not absolutely sure there was actually any inflammation in the heart, is a bit guesswork, I think. So that's what I wanted to say. I don't think this is a matter of plotting out an exact regimen, whether you add a second-line agent.
Yeah.
And that's why I've broken away from your questions, because I think the issue is more, what do we have in the heart to start with, given there's no signal on PET whatsoever after only a month of immunosuppression?
Yeah. I think, is there any more question remaining? Just let me see. So the expected disease behavior.
Do you agree with what I've just said broadly?
Yeah, I do agree, sir, because I believe that the 60 milligram dose was quite overzealous. I would have stepped down. I will do that. His diabetic was monitored when he was inside the hospital. I discussed with all the nephrologists and endocrinologists. Then only we started because we were worried about hypercalcemia and creatinine of 2.5. So that was the reason. But immediately we will step down. The only thing was when should we start? Because when the multi-system sarcoidosis involving heart, or in this case at least kidney, liver, spleen, all those things are there. Should we just wait till steroid response, or we should start add-on therapy?
Your difficulty is what you mean by a response if you don't have a baseline signal of inflammation. And there's one key question we're not discussing. If this is really cardiac sarcoid with an ejection fraction of 30%, I would expect quite a lot of late gadolinium signal on the MRI. If that's true, this patient needs an intracardiac device to avoid sudden death, whatever else happens.
Yeah.
And even if there's a lot of inflammation, you may improve the ejection fraction with pump support. I don't believe you've got a very good chance of improving it much with steroid therapy and immunosuppression. It's obviously crucial to prevent further progression and increasing damage.
Okay.
But the problem I have with the whole management is complete uncertainty whether there was actually any inflammation in the heart, whether or not the MRI scan shows a lot of scar tissue, and you can say, yes, we know this is cardiac sarcoid. I'm not sure what we're treating exactly in the heart. Sajal, do you actually broadly agree with my points?
I completely agree with you, sir, on the issue that whether it is cardiac sarcoid or not, the issue of systemic sarcoidosis, involvement of the lymph nodes and lung is not there. That diagnosis is very much sarcoid. But yes, as you said, that's why I asked the time lag between the imaging and the steroid therapy. And you are very right that the inflammation will not completely disappear. And at least we must see some scar tissue on the MRI. Secondly, I also agree with the steroid regimen used. That was what I was about to question. That because even if he has hypercalcemia, it could have been managed by hydration. Even if the EF is less, the patient may be slowly hydrated, and that may be the first line of treating hypercalcemia. If you really want to change the diagnosis in the coming 2 or 3 days, if you are really able to get the calcium down with hydration, and as well as zoledronate could have been used, and then you could have put the patient to further investigation so that you don't lose the opportunity to make find what kind of inflammation occurs in various organs. I do not agree with the idea of just doing a PET CT in the first place, the whole body PET, because it doesn't really add to anything. If we have that typical CCT and a high resolution CT scan, which is giving us the diagnosis, and even an ultrasound could have shown us how much is the liver spleen involvement. And sometimes I will use a fibroscan if I really have to probe hepatic sarcoid, if the enzymes are raised. So we could have got a GGTP, gamma glutamyl transferase, along with alkaline phosphatase, so that if they are raised, then I would suspect significant hepatic disease.
I showed it. It was raised. Alkaline phosphatase,
Yeah,
GGT
ALP was okay. So there I would do a fibroscan to just look at the liver elasticity and any fatty deposition, which may be relevant. But yes, any progression to cirrhosis or hepatic fibrosis, an ultrasound to look at the hepatic echo texture. So all those things to look for the systemic involvement, but not a PET. I do the PET initially only for the cardiac part and not for the systemic disease. The dose, as Sir rightly said, that it could have been just 30 to 40 milligrams to start with. And along with hydration and zoledronate, it could have taken care of the hypercalcemia easily. The last thing that I want to mention is that you may not say that it is renal sarcoid. Renal sarcoid is when you have granulomatous inflammation in the kidney.
Yeah, secondary.
You don't know in this particular case, but most likely it is the hypercalcemia which has led to the AKI. So renal sarcoid is not a very common diagnosis in all these patients. So you cannot say that kidney is involved with sarcoid really.
Yeah, agreed for that. But I agree that we might be tend to over investigate the patient, and we do not. I'm not apologetic about it. I say that I do PET CT if I feel like doing, because ultrasound and all, finally the answer will be PET CT. So I may not change doing what I am doing because this thing. So
to be fair about this, I think if you're convinced the scan shows sarcoidosis, you don't need the PET signal. But the PET signal of involvement of lymph nodes is often very helpful in those cases where the scan is less definitive but suggestive of sarcoid. So it's a case-by-case thing, and you are critically dependent on what a radiologist concludes in looking at that first scan.
Yeah, I think we will move on to next case because we are really very slow today and I'm worried about how we are going to finish it. So let me start this, share my screen again. And this should be the second case is about one lady who has never been biopsied. So she is a 56 years old female who presented with systemic hypertension, diabetes, cough, breathing difficulty, palpitation, and intermittent fever. She had family history of tuberculosis in her family. Her mother had. She was presented again to outside hospital and endobronchial biopsy was taken, which was reported as a carcinoid. However, key index was low and she was never treated for that. They just have decided to observe her for that. But when they did a CT scan, they found something else. They found that there were multiple lymph nodes for which right supraclavicular lymph node biopsy was taken. And it was reported as a granulomatous inflammation. All the other workup was negative. Manto once again negative. Overall features were suggestive of sarcoid type granulomas. I do not have biopsy slides for this. And I will stop sharing my slides and sir can go ahead with CT scan because there is nothing more than that in this particular patient.
So this is the CT scan, and the date for this CT scan, just for us to keep a tab, is from November 2023. And on the left-hand side, what you can see are these large lymph nodes in the axilla, very distinct lymph nodes in the axilla bilaterally. And in the mediastinum also, we are seeing few lymph nodes which are extending into the subcarina, some coronary artery disease. When we see the CT in the lungs, couple of things which are very important here. Let me just change this. This has got slightly better view. You can see the endobronchial lesion across here, just across there. There's some endobronchial irregularity in the right upper lobe bronchus, which is what I suspect was biopsied. And then you're seeing a lot of peribronchial inflammatory changes, soft tissue nodular thickening in the right lung more so than the left lung. What is more interesting as we go down is right middle lobe bronchiectatic changes, but then the disease pattern changes as we go more towards the lung base, and you can start to see subpleural areas of honeycombing have started to settle in both the lung bases. So at this point in time, you can see there are central disease, bronchocentric areas of nodularity, which fit in well with the lymph nodes and sarcoid. And then there is atypical features that we are seeing in the lung bases in the subpleural aspect.
So then coming to my questions. So then the investigations which were done outside were biopsy and everything. The patient presented to us for a follow-up of her carcinoid tumor. And because carcinoid, as a part of carcinoid tumor follow-up, we did a repeat CT scan over here. That time, these are the recently done investigations. And I could not find anything other than uric acid and creatinine was slightly on a higher side. She is diabetic and her HbA1c is 9.9. So these two things were really worrisome. Otherwise, mild anemia, nothing great. Her PFT was relatively all right. Her ACE level was 63 units per liter. We also tried to do axillary lymph node biopsy in our hospital, but it didn't. It just showed fatty tissue. So I could not confirm diagnosis of sarcoidosis in my hospital, but it is irrelevant because we can see there was a lymph node and granuloma outside. Her room air saturation is 97%. Our CT scan was given. I have not started her on any treatment because she was never started on treatment for either diseases. So the questions to the panel was, are we going to see the 2024 CT scan, Vimal Raj sir? Or you showed it?
I can show that.
Yeah, we will. I will just show that CT scan and then we will go to the questions.
So this is the follow-up CT. So we have two CT scans, the one which you had initially seen, which is on the right side from November 2023, and this is from May 2024. And the lung parenchymal changes, these are thick cuts. We don't have the thin cuts for the most recent scan. The lung parenchymal changes, you can see some nodularity along the bronchocentric areas. The soft tissue, irregular nodules in the right lower lobe, right middle lobe are all persistent. The axillary lymph nodes, etc., are also unchanged. You can see these lymph nodes slightly reduced in size, but they are still there. Multiple lymph nodes bilaterally. And at the lung base, if you remember, we had seen the subpleural honeycombing changes. They are all persistent. So between November and May, 6 months gap, there is almost pretty much similar. The endobronchial lesion, whichever was there, has now gone. There's no endobronchial lesion at this point in time.
Okay. We have a patient who is relatively asymptomatic. I believe it's like the first question definitely is it sarcoid. I have granulomatous inflammation in one biopsy, no granuloma in another biopsy. The second question is, do we need to treat it? And if yes, for treatment, what drug I should start? And is honeycombing a sign of fibrotic sarcoid, or there are two pathologies going on? Shall I stop sharing? Yeah.
Yeah, Dr. Smita, maybe I missed it somewhere. What happened to the carcinoid? What happened?
Yeah,
to the
so carcinoid, the oncologist is up to it, and because key index was hardly 11% or something, they have suggested her to follow it up. Nothing else.
But
We did rotated scan. It was not metastatic.
In the follow-up CT, there was no endobronchial lesion.
Yeah, so I believe it is not seen in that, but our radiologist has reported it is status quo in the lesions are status quo. It's not increasing in size. So it has not gone anywhere. And
So
we have decided not to treat it.
So I have thick cuts. Maybe that's why we missed them. So I don't have thin cuts in the
because I
most
could
recent.
not. There were plenty of images. Some images might not would have transferred. You can understand there are 500. Okay,
So
but our radiologist has and oncologist has decided not to do anything about it because the key index is low and follow up is the.
So okay. So I'll just take 2 minutes to make a comment and address all the answers, all the questions. So the first thing is that what is sarcoid? Sarcoid is basically a granulomatous reaction to some unknown antigen. So this kind of reaction may occur due to microbes, due to environmental antigens, etc. So here there's a tumor which is possibly inciting this particular granulomatous response. So what happens with a sarcoid-like reaction in case of tumors is that the draining lymph nodes will develop these granulomas as part of tumor antigens, and mostly it will remain limited to those regions. But sometimes these tumors are associated with a systemic sarcoid-like response also, and we really do not understand when this switches to from a local response to a systemic response. In this particular case, the workup that you have shown for extrapulmonary involvement with sarcoid, it mostly shows that no particular organ is really involved with granulomatous inflammation, and there is no organ dysfunction occurring in the usual organs that we see which are involved with sarcoid. So on the treatment part, I would say that it needn't be treated, but the patient needs to be observed, because in rare cases, or maybe I would say uncommonly, all the tumor itself can evoke a systemic sarcoidosis-like response, which might need treatment later. Whether it is sarcoidosis as we know it with an unknown antigen, no, because here most likely it is the tumor antigens which are inciting this sarcoid-like reaction.
Sure.
Again, I don't need to treat it. When you need to treat it, then again steroids, low-dose steroid will be the first choice of therapy. The honeycombing that we encounter in cases with sarcoid may be of two varieties. One, it can be really fibrotic sarcoid disease, which starts along the airways. So there's a lot of peribronchovascular distortion, and honeycombing starts more centrally. So that is a honeycombing which results from sarcoid. But in a lot of cases, we see a sarcoid IPF overlap, or basically the honeycombing is forming a UIP pattern in this particular case, and it is not related to the sarcoid-like reaction that we see. That is what I believe, but we will have opinion from Dr. Wells.
Yes, sir. All yours.
I'm going to agree across the board, but with some minor nuancing. So I'd be calling this sarcoid in London, but I wouldn't be pretending I knew more than Sajal, or as much as Sajal, about diagnosing sarcoid in TB endemic areas. So I would be saying that the carcinoid bit, I can't make sarcoid. There's granulomatous reaction identified in lymph nodes. If you then look at the other changes in the lung interstitium on CT, personally, I wouldn't be quite as confident as I was in the first case. So my major concern would be that this might be TB. And I'd also be reassured if Sajal was able to say that he knew it wasn't. But we got to stick to our strengths, and mine is not diagnosing sarcoid in a TB pandemic area.
Cultures were sent, sorry to interrupt you, the first time when we did biopsy, all the cultures, gene expert, everything was sent was negative. And that is why I didn't do biopsy again.
I agree. And it's very important you cultured the biopsy. That's crucial. I think that's where you lose your ability to pick up TB. You look for TB in other ways, but you don't culture the biopsy. And you did that. So I think that it's very fair at that point to regard this as sarcoidosis. It's just that when you follow the case, you've got to be very alert for unusual behavior.
Sure.
So I think that's that basis. On treatment, I agree. There are two reasons to treat: danger and unacceptable loss of quality of life. And this patient ticks neither box. We have a tsunami of overtreatment with steroid, with terrible steroid-related comorbidities in our sarcoid history. And I come, therefore, quickly to the most interesting question for me personally. So we did this multinational sarcoid phenotype exercise, and Sajal is now part of an 11-center worldwide initiative to take this further. Now, we didn't get agreement on a UIP phenotype, and I think that's because UIP means different things to different people. But I think there are features of this scan that point very strongly to this being a sarcoid subphenotype. And I say subphenotype because it is mixed in with nodules. And so we actually have an overlap of two phenotypes. The feature that points to me is that it's what you call exuberant honeycombing. So it's not that exuberant means extensive, it doesn't. It means you're traversing from normal interstitium to quite spectacular honeycombing with nothing in between. We see this in rheumatoid lung, and in my view, we see this in sarcoidosis. And I think you don't always get the honeycombing in a IPF distribution. You can get it in the upper zones, and you can get it along airways. But in our revised Sajal phenotype exercise, I believe we will end up with describing what you're describing as well. And we were close to consensus on this in the Delphi exercise.
Okay. So I believe the answer is not to treat, and honeycombing may happen in subphenotype of sarcoid,
There's
right?
one more thing to say that's terribly important. Once you see this phenotype with honeycombing, it can behave in one of two ways.
Okay.
It can behave like IPF,
Okay.
or it can actually sit there stable. And you really have to monitor this like the patient has early IPF.
Okay.
I hadn't heard what the DLCO was.
It was normal. It was normal.
That's reassuring, because usually with an IPF-like process, you get reduction of DLCO when you see this, but the exuberant nature, moving from complete normality to what is very limited in its volume, probably explains why the DLCO is normal.
94% of expected. It was normal. So I will observe her three months spirometry, PFT, DLCO, and maybe annual CT scan. Is it okay?
I think in this case, you do need to come back with another scan. I wouldn't go on and on doing it. If you establish stability over a year, you can then watch the lung function and decide how to use CT.
Sure. If necessary, I won't do. Okay. Moving on to third case.
Asmita, can I make a comment on that?
Yeah, please, sir. Go ahead.
Yeah, just quickly, I agree with Athol. We've had one patient like that going to transplant, and we've had another patient who's going on for 8 years, 10 years without any change. So it's exactly what Athol said. It can go either way.
And I think it's a 50-50 split, roughly, although slightly more in the IPF-like than in the stability group.
Sure.
Okay. Shall I just move to the third case if it is fine? My slides are visible, right?
Absolutely. Go ahead.
Yeah, okay. So this is the final case. This is 59 years old man who this patient who presented, this is the case which Sanmukh Sundaram sir was confused about. So this was the case of 2020 history of syncope. He was diagnosed with high grade AV block and he was treated with PPI on 7th February 2020. But even though his cardiac problem was taken care of, he had continued RWMA and complained of cough with yellowish expectoration for last 2 months. This patient again had weight loss. Over 8 months, he lost 16 kilo. So he presented to cardiology department of our hospital with progressive decline of ejection fraction and scarred basal segments on echo. He was found to have ACE level of 89. My cardiologist gave me a call and told me that this looks like sarcoid, Asmita, can you do something? And then on examination, he was perfectly fine. This was his ECG at the time when he presented to us. The PET CT scan was taken. I will just come back to it after I will show you the other investigation. Inflammatory markers where ESR was high, ACE level was high, Manto and quantiferon TB gold was again negative. PFT was relatively well preserved. We did biopsy for him and this was the biopsy slide, multinucleate giant cells and non-necrotizing granulomatous inflammation. I will just stop sharing my slide and Vimal Raj sir can just show the images and then we can take the questions.
So this is the CT component of the whole body PET CT. And what we are seeing in this patient, there were small lymph nodes, not too many, but there were at least mediastinal lymph nodes, subcarinal lymph nodes. And we can see that the patient has already got a pacemaker. And when we look at his lung parenchyma, very classical clusters of these nodules, we can see spread in a bronchocentric distribution, bilaterally more in the center of the lungs. There was some perihilar inflammatory changes at that time, some patchy areas of bronchial wall thickening and bronchitis. This is the PET equivalent compared to what we had seen earlier. If you remember, the entire heart was lighting up. Here the whole heart is not lighting up. So this is, I presume, after fasting, and whatever you're seeing now are areas of involvement of the myocardium with the inflammatory tissue, and we can see the same changes across the lymph nodes and the lung parenchyma in the perihilar region.
So
I ask a question about this. Do you measure SUV max on the PET, and what was the SUV max?
I'm not
We
sure.
have measured, sir. We have measured the SUV of this patient, and it is very interesting to note that the SUVs are more than 15, 20 like that, even in the myocardium also. And as we were discussing previously, this particular patient had a rest myocardial perfusion scan with system EB showing large areas of scar tissue, and exactly matching with that is the increased FDG uptake. So we thought this particular patient will have a good response to steroids and specific anti-sarcoidosis treatment, because we were able to show active inflammatory pathology, mainly involving the entire myocardium and also systemic disease in the form of liver, spleen, and also infradiaphragmatic, supradiaphragmatic, and mediastinal lymph nodes. Skeletal tissues were also there.
I have a couple of questions in that case. Did the PET signal extend into the right ventricle?
Specifically, yes. In this particular patient, we did not see the right ventricle increased uptake. But of course, as you rightly pointed out, we always look forward for that. So here is a patient with classical large perfusion defects, matching with that increased FDG uptake. So this particular patient shows the stage to be in active disease stage.
And can you tell us about damage as opposed to inflammation, the late GAD signal on the MRI? Was there a lot of scar tissue?
Yeah, so in this particular patient, we had classical mid-myocardial and epicardial scars, exactly corresponding to all these areas with delayed gadolinium enhancement also.
Lovely. And on CMR, on MRI, what was the ejection fraction?
I'm not remembering, but I think it was somewhere around 35%.
Okay, so this is all lovely, isn't it? It's a classic case on advanced imaging, and you've got the systemic support. And it drives management with great certainty, and I'm sure we'll come to that.
Yeah, so this was, as sir told, he presented in 2020 with syncope and a very high grade AV block for which the pacemaker was inserted. And then 2024, he presented when we picked up that it was sarcoidosis. So question to the panel was 4 years since the cardiac presentation and the respiratory symptoms. I'm not sure whether respiratory symptoms were present. I specifically asked whether X-ray was taken. He told nothing was taken that time, just treatment of cardiac problem was done. So was it sarcoid from the beginning? Do we need to give second line immunomodulators, and ideal time for starting immunomodulators in such patients other than steroids?
I think we just have 5 minutes, so I think I would like to hear Dr. Gals speak on this.
Yeah, look, I think this is more straightforward. The first thing is this patient needs an intracardiac device without a shadow.
Yes, we are planning for that.
Now, this is important. When you give this, you need to put the device in before you give the steroid therapy, because steroid therapy can cause unequal suppression of inflammation across the myocardium and can trigger major ventricular rhythm disturbance. So you really need to put the device in first.
Okay.
And I've seen that a number of times. We've worked that out. It's in the literature. Secondly, your three approaches with treatment are induction therapy, cardioprotective therapy, when you've got low-grade inflammation, less damage, maybe a minor ejection fraction reduction, a whiff of LGE, and you think that ongoing failure to treat will cause progressive damage. This patient is clearly induction therapy. The SUV max threshold we tend to use is 6. The SUV max is 15, but it's also moderately extensive. It's not a tiny focus. Fortunately, it doesn't go into the right ventricle. So you're going to go for high-dose steroid therapy. You're also going to know you must get the dose of steroid down. You know that low-dose steroid monotherapy won't cover this. So you start the methotrexate from the outset.
Okay.
And we've got a process. We give methylpred because it allows us to bring the dose of steroid down immediately to 20 milligrams daily. But in this case, I would say that you go to an early repeat PET because you need to know you're winning. And if you aren't winning, that's when you have to think about what else you might add. So I mean, some people use the oral steroid.
Early PET-CT means how many months, sir?
I think you would be talking to the patient, but you'd be saying in the broad margin of 3 to 4 months, maybe 3 to 6 months. This is a case you're worried about because there's a lot of damage. I don't believe that, I mean, you may see a marvelous treatment response, but I strongly suspect that only pump support is likely to improve the level of cardiac dysfunction. And you're stuck with the cardiac dysfunction, unfortunately. So I think best management is likely to give you a good outcome because you'll prevent sudden death. But I don't think you'll get this patient back towards a normal ejection fraction for a moment. We used to try to do that, and I don't think we managed it ever from this sort of scenario.
Okay, I think we have 2 more cases. I'll move. Sujit Rajan sir, are you ready to present or should I give to Pooja?
We can start with Pooja. My case is a very short case at the end.
Sure. So Pooja, I will present the slides and you can start talking.
Sure. Thank you for presenting the slides. So this isn't sarcoidosis per se. It's just, for the pan-ILD meet. Our patient is a 73-year-old gentleman, a doctor from Karnataka, and I saw him while I was working at another hospital, so all credit to Department of Pulmonology and Radiology at Apollo Hospital, Bangalore. His comorbidities were hypertension. He did have an episode of COVID about 7 months prior to presentation, which was mild. His exposures, well, he's a reformed smoker with about a 10-pack-year history, and he quit about 40 years ago. Further exposures, he does have a pet cat, and he denies pigeon exposure. No features of CTD as well. He presented to us in June of last year and had an episode of a URTI at the time, cough, breathlessness. He desaturated to 83%, and a CT was done at that time as well. So the CT scan, if Dr. Vimal had a chance to take a look at it.
Yeah, we will finish this and then I will ask him to share. So what was his clinical presentation, if you can just save it? Yeah.
Sure. So it looked like a UIP pattern, and outside he was started on steroids and nintedanib. He then came to us about a month later. The cough had subsided at the time. However, he continued to be dyspneic with a grade 2 MMRC dyspnea. His saturation was 93%, no clubbing, and there were basal crepitations on auscultation. We evaluated him further. As you can see, there was restriction with reduced FVC done outside at presentation. And even with us in July, there was restriction with an FVC of 50%, a reduced DLCO at 39%, as well as significant desaturation on his 6-minute walk test. We did a CTD panel, which was negative, and other labs were negative as well.
Yeah, I think we will, Raj sir will show the images and then you can take the questions. Yeah.
Okay.
Okay, so this is a CT scan that we have for this patient, and what we can see if we start from the top, there is definitely interstitial changes extending from the top to the bottom. There are patchy areas of ground glass bronchocentric involvement within that, and all these areas of traction dilatation of bronchi that we can see extending all the way to the periphery. As we come down lower, you can start to see this traction dilatation of bronchi very prominent along the right middle lobe with central areas of ground glass opacities. Again, in the lower lobes, we can see all these bronchocentric ground glass opacity, traction dilatation of bronchi, going all the way down to the periphery. And in the periphery, some areas of early cystic change, and then some areas of spared lung parenchyma. These are all trying to getting conglomerated to becoming like a honeycombing, but I don't think they are fully there yet in this scenario. We don't have any expiratory scan. There are some patchy areas of what may be spared lung rather than air trapping. There was dilatation of the main pulmonary artery was a bit prominent, suggestive of a component of pulmonary hypertension also in this patient. So overall, what I'm seeing is a fibrotic interstitial lung disease. The pattern is indeterminate for UIP. I'm not calling it UIP because there's a lot of ground glass, and honeycombing is not the predominant feature in this patient.
Okay. So this was during an exacerbation. That's the CT that I was able to get for you. I don't have the very next CT, but when he came to us in July, the GGOs had come down considerably. So there were no GGOs, but the interstitial pattern, the interstitial reticulations, the traction bronchiectasis persisted. And we went with a diagnosis of probable UIP. And so to summarize, this is a 73-year-old gentleman with smoking history, a probable UIP pattern on the CT, restrictive pattern. And then he came in like, why me? He had denied pigeon exposure. And then when we spoke about, etiologies of ILD, he shows us this, the more history unfolded. You can show the next slide, please. He has a macaw in his neighbor's house. His cabin at the hospital where he works has mold in the walls. He has parakeets. So immediately after that, what we did was an HP panel, and the HP panel was negative. So my question to the team right now is, would you subject him to a lung biopsy now that we have more history, but an HP panel is negative? It's not exactly UIP pattern for us to write it off as IPF. Or would you consider this as, an HP with fibrosis and then continue steroid therapy as well?
Sure. So I will stop sharing and please stay. Yeah.
So the first thing is whether the diagnosis is fibrotic HP or IPF. So had we not got that history of bird exposure, first of all, we should ask about exposure to birds rather than just asking about exposure to pigeons, because parrot keeping is also a favorite hobby in India too. The other thing is the HV panel was negative because the panel which is available in India in most of the commercial labs, it just has the pigeon antigens, a mixed pigeon antigen, which consists of feathers, serum, and droppings. It does not have the parakeet antigen, which is otherwise available with the Thermo Fisher company.
So we did
and
a
they can
six
give
panel, a six
Yeah, so it has
panel.
molds.
Yeah, it
It
had
has
molds
molds
and it
and
had
it
pigeons.
has pigeons. So it does not have parakeet parrot. Hence, ducks. All those antigens are available for testing for IgG with the Thermo Fisher company. So it can be done in house if you want. The third thing is whether the diagnosis of fibrotic HP or IPF. So now we have a 73-year-old gentleman who is a reformed smoker. He has bird exposure and he has a low predominant disease. And on the CT, I do not see any mosaic attenuation. We do not have an expiratory scan to really comment on air trapping. But yes, there are some ground glass opacities, so the CT does not fit the classic or typical HP pattern. It rather fits more of the typical UIP pattern. It will be a probable UIP, but with all this history, it is very difficult on this data to really diagnose this patient with either of the diseases. Now, the risk and benefit of the biopsy would depend on how much change will. So as of now, we don't have real good evidence on how to treat fibrotic HP. We just know that steroids are somewhat useful in mostly in symptom relief. Whether steroids and immunomodulators really help in stopping the progression or delaying the progression of disease, we really don't know, and people are working on that particular question. So in that case, the risk of benefit has really to be discussed with the patient. And finally, this patient would end up getting antifibrotics because even if it is HP, such a fibrotic HP progresses in most of the cases in a year's time or so. So antifibrotics the patient will end up getting. We just need to decide about how much immunosuppression to be given to this patient. And again, I'll leave that to the discussion with the patient, the decision to biopsy. Professor Wells, please.
I'm going to comment on conditions, Sujit, then comments on my comments. So very briefly, I would not do a surgical biopsy on this patient or a cryobiopsy probably, and under those circumstances, a surgical biopsy. Until you came up with the bird exposure, I was going to say age, gender, smoking history. And I think that if you say the ground glass was actually part of an acute exacerbation, I think you're somewhere between probable and definite UIP on a scan. But if you call it probable UIP because you're taking out the ground glass now, it's an acute exacerbation, then I think you put that package together without the exposure, it's a definite IPF. Now, the question is, if you've got an exposure, well, a lot of people do. You can do a BAL to see if there's a lymphocytosis, because if there is, that changes your thoughts. And I think that's the only thing that would budge me. I'm not bothered about the negative antigens. Sometimes antigen positivity is specific to an individual bird, and let alone species, and then commercial preparations don't always cut the mustard anyway. But when it comes down to it, I believe you'll get UIP on the biopsy. The question is it UIP, IPF, or UIP, HP? And to me, in this case, the outcome's going to be the same. And furthermore, I don't think we have any data to indicate that the UIP subset of HP gets benefits from immunosuppression, especially in the absence of a striking BAL lymphocytosis. And I really do fear that by enthusiastically declaring its HP with UIP and giving immunosuppression, you may worsen the outcome, as was seen in the Panther trial, because we've got identical outcomes once you've got definite UIP at a biopsy, or you have some honeycombing on a scan in HP. It's an IPF survival with whatever on average we do. So why would you perform a biopsy procedure that might trigger an acute exacerbation? And you're going to antigen evict here. Sometimes you make an HP diagnosis to say we've got to find an antigen and remove it, but you're going to do that anyway here. So I'm not sure that a biopsy changes the treatment goals, changes the likely disease behavior, changes your monitoring strategy, or changes your actual therapy or prognostic evaluation.
I would like to raise just 2 points here. One is that in such cases where there's a lot of signs of fibrosis on the CT set, we hardly get any lymphocytosis. That has been our experience with this amount of fibrosis. And the other thing is that if I agree with you that a biopsy should not be pushed for and may not be done rather, but the only question is between IPF and HP, if we are able to differentiate in this patient, would you consider a low dose steroid in HP and not give it in IPF if we get a such?
I tend to end up being a wimp and covering the differential, but covering very cautiously. But I am acutely aware that I might still be causing damage. But like you, Sajal, I think I would say that it's fair to cover a differential. You don't have to say the diagnosis is A, but could be B, but I'm going to ignore B when I manage. So I can see the argument for that. On BAL, we ourselves support what you say in a way. And the only thing I would say is you've got recent ground glass, which may mean you do get a BAL yield. But in our own analyses, once you've got disease at a certain extent, you can see a BAL lymphocytosis, but it does not go with different outcomes in the end. And this is across the spectrum of HP, IPF, and unclassifiable disease. So I think that you would be more saying that maybe it gave you a guidance on whether HP was more likely if it's there. But I do agree with you, the yield is likely to be low. So I wasn't pushing that strongly because I think you've got the biological entity here that is going to drive disease behavior and management, and that is primary stroke secondary UIP. And then like pH, you find pH, then you subgroup that and you say, okay, we better think about covering HP UIP. Antigen evict, and you can make an argument for some low-dose steroid. Sujit, what do you think? Because you...
Yeah.
Yeah, please go ahead.
If I'm okay.
Yeah, you are audible.
Whether if the patient was to opt for a steroid trial before antifibrotics, would you agree to that?
I did not see the second scan, I think, to see how much ground glass there was. And I think that I'd perhaps be a touch concerned about steroid therapy at anything more than a very cautious dose. I think.
Only because the patient would say antifibrotic would be lifelong. So can I have that window to gain lung function with a steroid trial? I mean, we've had these patients who have asked us this in the past. So I was wondering whether you would oblige the patient with a trial.
Well, let me say that if I really did think it was worth doing that, and I think looking at a scan, you do get a sense whether a response is realistic. Now, apart from the ground glass that we think was an acute exacerbation that went away, I was struggling to see anything on that scan that I think would respond to steroid therapy. You would be adding it to try to reduce decline if it was an HP pathway. Now, I think if the patient was really set on it, I really would think about establishing this a BAL lymphocytosis, because otherwise anything more than something that is hardly a proper steroid trial, a low dose, does, I think, risk problems in this subset along the lines of Panther. So
sure.
It's a nice debating point, actually, because you both know that you actually need controlled data. And you can't do that for HP across the board. This is a subset of HP with UIP. That's quite different from fibrotic HP with bronchocentric fibrosis, and that's different from fibrotic HP with an NSIP fibrosis, and it's different again from fibrotic HP with admixed inflammation that is significant with, quite a lot of ground glass responding to therapy. So we don't have controlled data, so I'm making it up, you're making it up, and we can actually decide who makes it up better.
Okay, I think Pooja, are you okay with the answers that
Thank you. That's
they are in the
good. Thank you
opinion
so
that
much.
no biopsy
Right.
and no steroids either. So shall we
Yeah.
just move on to the third case?
No, just to be fair, we left the steroids slightly open.
Yeah.
Okay, fine. Agreed. So last case, and we are already 6:15, sir. So maybe we can wind up fast. Over to you, sir. Can you read or I will read for you?
No, I can read it.
Okay.
It's one slide, contains everything.
Sure.
66-year-old male, married businessman living in Mumbai, never smoker, with a BMI of 32, had a routine chest X-ray done on a routine health check, right low zone haziness, and advised to start 2 antibiotics by his GP. So he came to me because he had seen me earlier for something. No fever, no leukocytosis, chest X-ray 2017 normal. No dyspnea. He inhales camphor during a festival season every year, but there's no other relevant exposure, no autoimmune symptoms. His father is asthmatic. His first cousin and uncle have sarcoid, and one aunt, but she's an in-law, has sarcoid. Chest clear to auscultations, and that's the blood work you can see we got done, and that's his lung function. The first one in May was on the routine health check, and the second one is when we got it done with DLCO and a 6-minute walk. And I think, maybe Vimal can put across the scans before I ask the questions.
Yeah.
So this is the CT scan and kind of very classical changes that we are seeing. Nodular areas in a bronchocentric distribution in both the lungs, with some of these having the galaxy side that has been described. And as we go further down, again, bronchocentric areas, irregular nodules. There is secondary partial collapse of the right middle lobe with some loss of volume there, but pretty much similar disease, all in a bronchocentric distribution from top to bottom. No air trapping was seen. And when we look for lymph nodes, again, small lymph nodes in this time. We are not seeing any major lymph nodes, very, very within millimeters. These were not significant by size criteria. So on CT, it does look like a sarcoid in the lungs.
My questions are, Asmita, can you put up those questions?
Yeah, I'll do that.
He's got this family history, as you can see, of sarcoid. One of those patients I'm treating. Should we proceed to bronchoscopy, lavage, and biopsy? Should we just monitor, as Athol says, MECO, masterly inactivity with cat-like observation? Or any other blood work you would do besides this? This is where I'm confused. I'm not able to tell him convincingly what we should do, but this was all on a routine health check, and these are his lung functions. DLCO well preserved. Sejal, that's all.
Can I go
Yeah,
first
so-
on this occasion, because I suspect Sujit is not confused. I think he knows exactly what he wants to do, because he's an expert in talking to the patient about biopsy decisions, and in a 66-year-old businessman, you sure want the patient participating here. So let's agree with the family history in the scan. The diagnosis is going to be sarcoid, and you've got 2 algorithms. You can be Mr. Squeaky Clean and always biopsy, or you can take a considered decision with the patient that actually the algorithm is to simply make sure that there's nothing atypical developing with time and move to a biopsy if that's the case. And I'd expect the patient to take quite a strong view. And I know you also buy in, Sujit, that if this decision is a close call, but the patient takes a strong view, it's not a close call anymore.
Absolutely.
And so let's just say that we shouldn't pontificate on what it's right to do here, because it's all about the discussion with the informed patient. Now, let's
Sure.
suppose the patient said, you're the doctor, you decide. My preference here, there's no danger. The scan is classical. The quality of life is not an issue. My advice would be that you can choose to observe. And the main thing is, you say Myco. Traditionally, people have used Mycos, and that's masterful inactivity with cat-like observation and steroids. And, and that is to be avoided.
Okay.
So, look, I could understand somebody saying, you must always biopsy in all cases, but I reckon this is not the 1980s. The doctor doesn't come into the room with an orchestra playing the arrival of the Queen of Sheba and declare there's going to be a biopsy. It's not like that. This has to be discussed with the patient, with a joint decision made. And that's the best decision if the patient has a role in it. But you can't be a wimp. You've got to...
Would you biopsy in Chandigarh?
Yeah, Shajal, please go ahead.
Dr. Rajan, our practice is to biopsy all patients unless there is a contraindication or there is complete unwillingness. But I completely understand the contrary view that some patients may not want a biopsy, and even physicians might take side of not biopsying most of these patients. But only thing that I want to stress upon is that just because somebody has a family history of sarcoidosis, in India, we don't know how this familial sarcoid also behaves and what are the triggers for the kind of sarcoid we see. So tuberculosis always remains a possibility. Because this patient is asymptomatic, I would agree to observe, especially if the patient does not want a biopsy. But at the drop of a hat, getting any symptom like a fever beyond a week or something like that, or a significant weight loss, I will definitely go for a tissue, at least a bulk for a CB NAT, that is cartridge-based nucleic acid assay, or even a biopsy. So that will be my view on that.
So one
And
question,
we can go ahead with a we can go ahead with a tuberculin skin test, because as opposed to an interferon gamma release assay, a TST is more helpful in patients with sarcoid. So if you see a TST of say 15 millimeters or higher, I would then really like to do at least a BAL.
Sure.
Yeah, I don't think actually, I think we can negotiate agreement, because Sujit, you may not have been here, but I made the point that if we're talking about diagnosing sarcoid in a TB endemic area, I'm going to take second fiddle to Sajal, because I operate in a non-TB endemic area. And I do think that's crucial. And so I understand your protocol. And on balance, my statement about observation is what I would do in London. But I would also want the patient to be able to decide on observation. But the great advantage of a biopsy and I understand this just from reading what literature there is, including, I think, the study you participated in, Sajal, with Bob Boffman, that in a TB endemic area, you can get things right by culturing biopsy tissue. Yeah. That's the key step. We would in London do a tuberculin skin test anyway, if there's any sense of background contact or any increase in the risk of TB. And I agree with you, it's a great screening test. And the interferon gamma tests aren't, I don't think.
Sure.
I think those are very useful points here. Thank you. Just Athol, one last question. With the genetic component, does that change your decision at all in any respect?
Well, it increases the likelihood, provided you're secure that they had sarcoidosis. It increases the likelihood that this is sarcoidosis. There's no doubt about that. And I think the only issue is that I just do have to listen to an experienced specialist in a TB endemic area. I've just got to take that aboard. But to me, in London, I think I'm just about there on the scan. Would I say that it's the only plausible diagnosis on CT? I'm not quite at the level where nothing else is possible, but putting together the CT and the family history in London, I would be happy not to biopsy in London.
Thank you. Thank you. I think both those points will be not making it a pitch for WASOG, but I think we're going to have talks on both those topics, genetics in sarcoid and TB and sarcoid. So, Nita, thank you so much. Thank you.
I think thank you so much, everybody. Sanmukh Sundaram sir, Vimal Raj sir for staying for longer than usual time. And yeah, we took longer than usual time, but those cases were worth discussing for. And I believe we got some fruitful discussion out of it. And Rajan sir, Pooja, all the cases were excellent. Thank you so much. Tech team, if we can just make it offline for us.
Well, I would have, we're offline now. I was going to congratulate online, but it looks like I can't do that. So
Yeah, we are still online, sir.
okay.
Yeah.
These are fascinating debate cases, and the only thing I would have said is that squeezing the 5 cases into the time, well, you did well to expand the time. That's all I've got to say.
Okay. Yeah. And
Thank you,
Sarda,
Asmita. It was a
yeah,
great learning
yeah.
experience for me also. So
Thank you, sir. Thank you for
assignment.
being with us entire time. And Sarda, I'm sorry, I was running short of time and it was clear-cut granuloma, so I didn't bother you, because if there was even single doubt, I would have asked. But thank you for being with us and tech team, if we can make offline. Thank you.
Yeah, so we are offline. If you want me to off the recording too?
Yeah, please stop it.